Welcome to Between the Sheets, the podcast where we're going to cover a variety of topics related to sexual health and wellness. I'm Dr. Stephanie Zwonitzer, your host. I'm a nurse practitioner and have been in practice since 2017. I have my Doctor of Nursing Practice degree, and I specialize in urology and sexual health. I am so excited to explore all of the various topics related to sexual health and wellness with you in a fun, spicy, educational, and non-judgmental manner. So come on, let's get between the sheets. Hey everybody, welcome back to Between the Sheets. I am here with a fantastic pelvic floor physical therapist. We have Sheree DiBiase with me today. She is with Lake City Physical Therapy. She also, she's been in practice for over 40 years, and she also has her own podcast called Femtech Health Podcast. So we're really excited to have her on today and talk about all things pelvic health.
Thank you for having me, Stephanie. I have been watching all of your podcast work and I love it. So I'm excited to be here today. And I'm just happy people are really wanting to open up the conversation about sexual health, pelvic health, et cetera. So thank you for having me.
Yeah, absolutely. Yeah, it's definitely, that was why I started the podcast. I just felt like it was an outlet for me to get information out, and there's so few quality educational tools that people can get great information on. So I just thought, let's go for it.
I love it. It's awesome. It's good.
Yeah.
We need it. We need more of it.
Yes. So talk to me about what patients are coming to you for, and how does that kind of relate to their sexual wellness?
So it's so interesting. I think, when you first start in the field of pelvic health, it stays really, clearly like, oh, pelvic organ prolapse, urinary incontinence issues, bowel health issues. And then, it really opens up the door quickly into sexual health. And we treat men and women in our clinics. And so we've been doing a lot of training, even in the men's health world, because what happens is we get the women coming in and they're like, hey, I'm feeling better. I'm feeling good. Hey, and now my husband, I need you to talk to him about. And, we do a lot of couples coming in together as well, because we just feel like, this conversation needs to be had. And like generationally and culturally, a lot of people can get closed down maybe about sexual health. So maybe they come in originally for something else. And then it always leads into this direction. And I'll just tell you, when I first started in this work, I probably left sexual health more towards the end. Do you know what I mean? I would make sure their bowel, their bladder was really healthy and maybe not have the conversation early enough. And, as I went further along in my practice time, I realized, no, I'm going to have the conversation about sexual health right from the start. Because most likely, if they're having bowel and bladder health issues, they're having sexual wellness issues as well. And we'd like to be able to get it on the front end before anything ever happens, so they don't have anything going on like dyspareunia or any of these things. And if we're not sort of speaking up about it early enough. So now in all the trainings I do with my staff and our team, we just talk about sexual wellness right from the beginning with our patients. And sometimes people are afraid or nervous, to say what their history is, or maybe what's gone on for them. And maybe some of those things trickle out later on, but we really are trying to help people have healthier conversations around sexual activity and quality sexual activity with their partners that maybe doesn't always include just, penetration as the ultimate, end range goal, right? To actually teach people the levels of intimacy, fun, pleasure. I mean, we really want that to be a part of people's lives. And if we don't have the conversation, people don't know.
Absolutely. And, that's one thing that I've been trying to work on in my own practice. I've always asked men, how are your erections? I've always asked my women, do you have pain with sex, when I'm asking them other questions about their bladder and stuff? Because I practice urology and sexual medicine. And yet I don't necessarily ask about their orgasms or their quality of sex, their quality of masturbation. And so that's one thing that I have started now when I ask my questions is not only, do you have any concerns about your erections, but now I'm throwing in there, or your orgasms, or your sexual health in general. And I say that to the women. Do you have any pain with sex, lubrication issues? Do you have orgasm issues? Anything that I can help you with sexual health wise? And I have found just by adding those couple extra things in there, I'm getting so many more answers and getting to the root of the problem much faster than I did previously.
I 100% agree. And I think that's why talks like this are so important
Yeah.
because, I was doing some work training with some male pelvic health therapists, and it was interesting just talking through even from a male perspective of
Hmm.
like, oh, well, this happened in standing position versus sitting position,
Yeah.
uh, you know, versus, oh, no, it never happened in that position, but only here. But if you don't ask, you don't know. And the same thing for women, like, oh, did it happen, in
Hmm.
this position, like, oh, it
Yeah.
only worked this way. And, I have a lot of women who are embarrassed to tell me that, like, they only have orgasm with external clitoral
Hmm.
stimulation, above the hood, around the hood, like, right on the ball, like, etc. Or,
Hmm.
and I'm like, no, that's okay. Like, these
Yeah.
are the conversations to know that, hey, these are all things that people say, oh, it only should happen this way. And
Right.
it's just not the case if we help women and couples in particular. I mean, I had one couple in one time who was basically sort of, kind of annoyed with each other because, she could have an external clitoral
Yeah.
orgasm, but like if they were actually doing penetration, she couldn't. And he was sort of perturbed with her. And
Yeah.
I said, well, isn't it beautiful that she actually had an
Right.
orgasm externally? Like, why
Yeah.
are we worried about like where
Right.
you think it happens, right?
Right.
And I was like, hey, that's the beauty of it. And what we don't realize is that, now some of the studies that are coming out,
Hmm.
I think there was a study with vibration above the hood, and it wasn't even directly on the clitoral bulb, but it was above the hood. And it
Yeah.
was like at that area above the hood, was amazing, actually, orgasms that happened in a huge group of women
Yeah.
versus like actually right on the bulb or other places. And I thought, like, those are the things that we don't know, and those are the
Right.
things that we should be researching and studying so that we can
Yeah.
help women. There's nothing wrong with you, like, you're
Right.
okay.
Yeah, yeah,
Yeah.
absolutely. It's so fascinating to have these conversations because, and I try to pay attention to that with myself too when I'm having an intimate moment with my partner or myself to be like, okay, what am I feeling? And trying to be more intentional about that so that I can have better communication and find the right words when I'm with my patients. Because it really does start with ourselves and our own comfortability of our own sexuality and our sexual health. And then we can talk to other people about theirs. And I found the more comfortable I am in myself and in these words, even just coming out of my mouth, that I can talk better with my patients.
Absolutely. I did a event. It was a couple of months ago, and it was interesting. We sort of asked, like, "Hey, how many of the women?" It was all, well, I guess there was women and men there, but how many of you have ever looked at your floor with a mirror?
Hmm.
And it was just funny because, like, I think generationally, it's hard because I think
Yeah,
the youngest woman in the group said she was the only one who had done it,
that is
and I
so
thought,
funny.
isn't it interesting? Like, I think generationally, maybe we were told, like men are taught how to handle their parts from
Yeah.
being a little guy, right? They're learning
Yep.
to pee. And so they're learning their parts and they learn how to handle their
Yep.
parts so they can pee. But I think women were told for so long, generationally,
Hmm.
that, hey, you don't talk about that, you don't touch that, you don't
Hmm.
do that. And so
Yep.
think of it, their own experience with it is not there. And one of my
Yeah.
big things that I've been after, Stephanie, is for, just like we do breast checks on people,
Hmm.
that people check their pelvic floors so they know
Yeah.
if something changes in their pelvic floors. And I think that's the thing, looking at the floor externally, like, is there
Hmm.
something there that wasn't there before? I recently
Yeah.
had a patient who had a small disc, like, I mean, it started out tiny and literally, the small as the back of your finger, like that.
Hmm.
And they didn't think anything of it and ended up turning into vulvular cancer. And it was
Oh,
so disheartening, kind of, because she felt something that felt different to her, and she
yeah.
literally was like, this doesn't feel like all the other tissue.
Right.
And I think those are the reasons that we're asking people to, like, hey, like, look at their floor,
Hmm.
actually check things, like, know if something feels
Yeah.
different than it did before, right? To,
Right.
like, actually know. But if, like, we've never looked at it, or we
Yeah.
never, like you said, you kind of experience, like, oh, well, that feels different than it did before.
Hmm.
Okay, well, why would that be? And so
Right.
I think that's the beauty of us, like, teaching people, like, oh, your pelvic floor is just like your oral cavity, right? It's no
Yeah.
different in a way. Like, it has these tissues that we need to take care of, and we're so good at taking care of our oral hygiene, but
Yep.
like, are we very good at our floors yet? Like that's,
Yeah.
I think, a huge push that we're after right now. I think when we look in the pelvic health world
Mm-hmm.
of being like, how do we make it just mainstream that you
Yeah.
just take care of your floor, and that our young people know how to take care of their floor, and they're
Yeah.
not learning from somebody who doesn't know, right? Like,
Right.
so,
Right.
hey, what should the skin look like? Is there redness? Is there rashiness? Is there an
Mm-hmm.
irritation to a mole that wasn't there before? External on the labia, or,
Yep.
on tissue right inside. I think those things are powerful things. And that's sort of the way. And think of it, if your partner's the one who's looking down there, why not let them look at you and be like,
Yeah.
hey, no, looks good, looks the same as it was. But you know
And
what? If
let's
we're
be
not
real, for our male partners, they're very visual. They love it down there. They want to see. Let them. And I can't speak for women, but I'm sure they feel the same way who like women partners.
Absolutely. Absolutely. Stephanie, I think this is the thing that, like, just helping people, like normalizing, we wouldn't
Yes.
let like a sore on our lip go. We wouldn't
Right.
let a sore in our mouth go. But like, we're going to not talk about something that doesn't feel good,
Right.
like in the floor. Like, we have all
Yeah.
these oral things we use if we got a toothache, or we
Right.
have all these things. But like, who's talking a lot of times, and I don't know about in your practice, but they will come in about other things, but they won't
Mm-hmm.
talk about the sexual thing until you say it.
Yep. Absolutely. In fact, I even have erection posters on my wall for that reason, to encourage my men to talk to me. And a lot of times they'll just point at it and say, can we talk about that? And I'm like,
Yeah.
yes, we can. Yes, we can. We should talk about that. Women are
Exactly.
a little bit more open with me, so I don't need quite the
Mhm.
visual. But
Mhm.
the men really, that it's exactly why I have that on the wall in both of my exam rooms, because they'll point at it and say, can we talk about that? Like, yes,
Exactly.
of course. That's called an
Yeah.
erection. That's a penis. That's a part of your body. Let's talk about
Yeah.
it. Like,
Well, I know, like, when we're doing training with our men, we're teaching them, penile lift,
yep.
testicular lift, we're
Yeah.
teaching them, hey, anal sphincter contraction. Like,
Mm-hmm.
I know sometimes people get so nervous about all of it, but these are just layers of the floor. And for men,
Yeah.
they do different things than in a woman's layers of the floor. I mean, they do closures, etc., but they
Yep.
feel a little different and they look a little different.
Yep.
And so just trying to help them as well have the understanding of, like, no, these are muscles and they can get
Mm-hmm.
stronger like any other muscle.
Yeah.
Because sometimes when they come in, I know in our office, they feel like, well, is it ever going to work again?
Mm-hmm.
Or is this ever going to
Yep.
happen? And I'm like, absolutely. Like, let's go and figure all of this out. So
Yeah.
I think it's important, because once they learn, that these are layers of muscles and they do layers of activity.
Mm-hmm.
And yes, they actually need to be trained just like anything else. If you think about it,
Yes.
70% of the floor is endurance muscles,
Mm-hmm.
30% are fast twitch muscle fibers. You realize, like, when we train, train for quick muscle contractions,
Yep.
5 quick maybe lifts, and then,
Yeah.
can train for more sustained holds and longer holds.
Mm-hmm.
I mean, the external anal sphincter is part of the floor. And even in those cases, it stabilizes at the base of the bladder for women's bladder. So at the neck of
Mm-hmm.
the bladder, if their external anal sphincter is stronger, it will stabilize the neck. So I
Mm-hmm.
think people understanding, like, we're not talking about traditional Kegels, we're not talking
Yep.
about things like that. You hear all these people saying, I don't know if you've seen on the internet lately, there's this whole thing about do no more Kegels. And I was like, okay, like, let's go back and
They
actually
still
have a
have their
conversation.
place.
Yeah, yeah, yeah.
Yeah.
And a lot of times, I mean, just so you're aware, like, and your listeners too, like, if you have a floor that's tighter than it should be,
Mm-hmm.
like it's a little hypertensive, I then turn around, I'm still going to train the muscles, but I'm going to train them in an elongated position.
Mm-hmm.
So, I might have somebody who's training anal sphincter and I have them up, like arms on their counters, butt sticking out behind them, and a Donald Duck butt, right? And I'm
Yep.
teaching them to put the tissue on elongation in order to strength train their external anal sphincter. So
Yeah.
it's no different if we're looking at a woman or a man. If they're a little shorter, a little tighter,
Mhm.
I had a man recently who was a big weightlifter and just had multiple hernias,
Mm.
like anteriorly, and we just went back to say, hey, it's no different though. You're still going to
Yeah.
train all these things. Yeah, you have some scar tissue, you have some things that we're going to work through, but you'll be able to get there. It's just like
Yeah.
you actually have to do the movement pattern, to do it. So
Yeah, it's interesting because I'll have patients come to me for leaking or premature ejaculation or prolapse, things like that. And they'll be like, well, before I could get here, my primary care just told me just do a bunch of Kegels. And I'm like, well, that's not wrong, but it's also not right. Like, if you are tight, doing too many Kegels is going to make things worse. And like you said, all of the layers that are there, you have to work all of them. Otherwise, you're going to be off, and that's just going to maybe change the way you feel pain or change the way that you have your issues. But you're still going to have some.
Absolutely. And I think that's, the vision of, whether it's, postpartum moms when they, like I'm trying to get all of our physicians to send postpartum moms in, right? So that,
Yep.
they don't have a leaky bladder for years. And then
Yep.
they wander in urology later and say, hey, I've had a leaky bladder for 7 or 8 years. And you're like, what? Like,
Yep. I
we
just had
always,
one today. I had a woman who had her baby in October and she is leaking. And I said, you are going to pelvic floor physical therapy. No ifs, ands, or buts about it. I said, nothing that I give you medication wise is going to do justice to pelvic floor physical therapy. So go.
yeah. And Stephanie, like in the musculoskeletal world, we just sort of look at, just like if we think about bladder wise, we look at it like, your deep transverse abdominis, your internal oblique fascially through the endopelvic fascia loves to go to that uterus, go to that bladder, and actually have an uplift because that fascial connection. So strength training, that deep abdominal core is powerful for the anterior part of the bladder. The
Hmm.
lateral sides of the bladder are stabilized by your hip rotators. So obturator externus loves to give support, but if it's too tight, gives too much pressure to the bladder, right? So
Yeah.
we want obturator internus and externus to learn how to actually rhythmically flow. So we're looking at hip internal external rotators and saying, hey, just like you have a shoulder rotator cuff, you have a hip rotator cuff, and
Hmm.
it directly affects bladder's function and bladder's ability to fill and empty well. If
Hmm.
it's too tight, it laterally gives pressure. And then
Yeah.
we look at the posterior part of the floor for women, with external anal sphincter, and levator ani contraction from the
Hmm.
rear, right, to give more stability to the base of the bladder. So when people kind of say, oh, I have a pelvic organ prolapse and they graded me a 1+, and oh my gosh, I'm always like, oh, no, 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 no. Like, no. And I don't know why, but pelvic organ prolapse, women, when they come in, they're so upset. And I
I know.
feel terrible about it because I think the vision of it is that, oh my God, everything's just going to fall out on the floor. And I'm
Hmm.
like, no,
Yeah.
but think of it. They feel heaviness. They feel
Oh,
pressure,
yeah.
they feel pressure against the bladder a lot of
Yep.
times, et cetera. And then they're afraid to have intercourse. Like I
Yep.
see that a lot with my people. Like,
Yes.
and I'm like, okay, hold on.
Yeah.
There's a
Yep.
lot of muscles working when we have intercourse, which is really good for
Right.
all of the floor as well. So
Yep. Yep. Yeah, and it's
yeah,
interesting because in going back to looking at yourself in the mirror and things like that, you'll notice your prolapse so much sooner if you're aware of what you look like.
yeah,
And then we can do interventions like pelvic floor physical therapy and pessaries and things like that before it
absolutely.
really becomes a problem. Women who I had a lady come in the other day for a pessary fitting, and her poor thing, she waited way too long and her whole uterus was out of her. I mean, she was grade 4, fully prolapsed, and it had been out for long enough that it was like shriveling. It
Yeah.
wasn't even holding its light bulb shape anymore. And I
Mhm.
just felt so terrible for her. I'm like, honey, you should have come 20 years ago and we could have, helped you prevent getting to this point. And so I really love talking to my ladies about their pelvic floors and all of that. And I love that there's becoming more pelvic floor therapists available because for a long time it was really hard to find the specialist.
Absolutely. And I think, if I could encourage young women out there to kind of go into, especially
Yeah.
women's health is an amazing specialty.
Yeah.
I'll tell you, it always rolls into men's health too. So
Yeah.
like, I always tell people like, they'll come on with me, Stephanie, start working with me. And they're like, no, I'm never treating a man.
Yeah.
And then all of a sudden, they're getting the wife better and she's doing wonderful and she's really invested in
Yep.
the work. And she's like, could you see my husband?
Huh.
And there's no way in the world that any of my staff ever turns down a woman when she says that to them,
Yeah.
because
Yep.
they've been so taken care of so well that they're like, okay, like
Yeah.
I'm going to learn all this. And literally, we that's kind of what we've done is like, you a lot of times, I know I started in the gynecological oncology world
Yeah.
first before I ever wandered straight into,
Yeah.
more of the other. And it's crazy though. I think that, you realize like, man, everyone has a pelvic floor
Hmm.
and we need to be like treating everybody and teaching
Yes.
everybody everything we know about it, right? Because
Yeah.
we need people to be healthy down there the rest of their life. And think
Yep.
about it, like if you can't pee well and you're an older woman, where do they put you? In a nursing home,
Hmm.
you know?
Yep.
And my older men who get fecal incontinence, I'm like, no, the moment you
Yeah.
feel anything that doesn't feel right, you need to be in my office and we need to be strength training. There's so many things that we can do to prevent that long-term, issue. So,
Right. Absolutely. And it's not only a quality of life issue, although that's huge for, all the people who, oh, I don't even leave my house anymore because I'm going to leak everywhere or whatever. But it's also, you get when you're wearing diapers and you're incontinent, you're getting skin breakdown. You're at higher risk of UTIs. There's so many other complications that can come from it, that let's go to the root of the problem
yeah.
and fix what we need to fix so that it's just not a problem. What are some of the issues, you talked about men coming to you. What are some of the issues that men are coming to you for? What can you help them with?
Well, a lot of my men come after prostate cancer surgery, it seems like, in our area at this point in time. And we've been really working with our local urology teams to really try to intervene earlier.
Hmm.
Because a lot of times, if I can get a man for maybe 1 or 2 visits, even 3 visits before they actually have surgical
Hmm.
intervention, or radiation, et cetera,
Yeah.
right? I can teach them. They're very visual spatial men.
Hmm.
And
Yes.
I use a lot of musculoskeletal ultrasound, real-time ultrasound, to show
Okay.
them, especially some of them that have more of that brain. But
Yeah.
even besides that, even if I don't have that, if I can get a hold of them and teach them how every layer of the floor works already,
Hmm.
then they with just easy stuff like, like I said, a penile lift,
Yep.
testicular lift, oh,
Yep.
pulling up those sitter bones and lifting them,
Hmm.
pulling them together, lifting anal sphincter contractions. If I teach them that before and they feel the floor finally, so giving that proprioceptive awareness, like, sometimes maybe I even have them just on a big yoga ball,
Yeah.
and so they can feel it off the ball. So they get the
Okay.
sensation from the front of the urogenital triangle, they get the sensation from the rear of the triangle, and they learn, that's where my floor is. Oh, I didn't even know what
Yeah.
it was. So they learn that, and then it's so much easier afterwards because, then we
Hmm.
get them draining that whole area after surgery, because there's a lot of lymphatic drainage that will
Hmm.
sit kind of almost pocketed in that lower abdomen, pelvic girdle region. So we teach them how to prop their pelvis up, put a pillow under their butt. Do you know what I mean?
Hmm.
So that pelvis
Yeah.
is sort of rocked backwards.
Yep.
And we teach them all that draining stuff early on.
Okay.
Um, and that seems to get them started. And then we kind of teach them, okay, and we have layers of things that we show them,
Yeah.
but we're on them so much earlier and faster. The same thing with our pelvic organ prolapse patients. It's no different. We're
Hmm.
literally trying to get them, train them as best
Hmm.
we can. And then if they really do need a surgical intervention, we feel like we've already taught their body so many
Hmm.
things. And then post op, they do so much, they do 10 times
Yeah.
better. I mean, one of our physicians literally just, he said, I want to know, I sent you like 3 people that wanted to
Hmm.
have, pelvic organ prolapse surgery. And I said, no, basically I said,
Yeah.
no, your floor is too weak. Your muscles are too, you have to go to PT first. And
Okay.
I tell you, they do so well that a lot of them will say, hey, maybe I could put this off,
Yeah.
especially if they reduce. Sometimes they'll reduce a grade. And,
Yeah.
you think, if they're a 1 or maybe a 2, sometimes you can get a little bit of reduction and you get
Hmm.
muscle tone, because guess what? They're going to have to come in afterwards anyway
Right.
because they're not strong enough. even
Yep.
if they did a great repair, they're still not strong enough. And
Right.
the likelihood that they might tear, and I probably see more in pelvic organ prolapses, tears in the rear of the floor,
Okay.
with a rear repair than
Yep.
an anterior repair.
Okay.
The anterior repairs of a lot of the people that I work with do absolutely perfect, and they do beautiful. And the rear repairs, and I know it's because if they're not haven't come to PT before,
Hmm.
they're bearing down too much with their first poop after
Yep.
surgery and
Yep.
just tearing the thing up. Whereas, like, if we're prepping them, and that's the same thing we do with men, we just prep them. Hey, these are all the
Yeah.
things that are going to go on. And I tell you, we don't need that many visits for our men
Yeah.
beforehand. And then explaining all these things. And so many of my men then do 10 times better. And then we don't have as much
Yeah.
erection issues or blood flow issues. And,
Sure.
which kind of brings me to the next thing of just sex in general. Like, I want people to know that sex is blood flow, blood flow, blood flow. So it is
Yes.
going to keep your tissue so healthy down there,
Yes.
men and women. And I
Yes.
think I saw somebody's data up about, like, how many times a month for different age brackets
Yeah.
people are actually having sexual intercourse.
Yeah.
I was like, okay, we need to do better than this.
Yes. I know there's a statistic out there that came out recently for prostate cancer that men who ejaculate 21 times a month have a
Yeah.
20% reduction in prostate cancer than men who only ejaculate 7 times a month. And I thought, do you know how many of my men are only 5 to 7 times a month, maybe even four,
Yes.
the once a week? And
Yes. Yes.
come on, guys, like let's get
Yes.
after it. Go for it.
Yeah. Yes. Right. It's exactly the conversation. I was just doing a male training with all of my staff, and that's exactly what I said. I was like, I had heard that statistic, and I kind of shared it with him, and I was like, don't be afraid to talk about masturbation. I think
Yes.
there's a lot of confusion. Do you know what I mean? Just culturally,
Yeah.
religiously, et cetera. And I think when you look at appropriate, like
Hmm.
masturbation, you're like, it's actually healthy because you're
It
actually
is.
getting so much blood flow to a
Yep.
tissue. Years ago, I took care of a particular group of women who were in a more strict, Catholic
Hmm.
sect. And it was super interesting. The one gal, she really wanted to understand and learn because she wanted to go back and tell all of the other women in her group, listen, you know what? You need to be actually having sexual activity because it's
Yeah.
actually healthy for the tissue
Yeah.
and it'll keep you healthier long term. And if you look at it, a woman can have an orgasm till the day she dies. I
Right.
mean, really, like, come on, right?
Yeah.
And so I think, knowing and understanding, okay, how are we keeping our bladder and
Hmm.
our bowel healthy? How are we keeping all these layers of the rugae of the tissue
Hmm.
healthy? It's by activity.
Yep.
Even my postpartum moms, sometimes when
Hmm.
they come in and they haven't had sex for 3 to 6 months, I'm like, okay, hold the door. Like,
Yeah.
what's going on? Like,
Yeah.
talk to me. Like, what's
Yeah.
wrong? Do you feel afraid? Do you feel like something's going to tear if you do?
Hmm.
You like, talk to me, because I think
Yeah.
that's the only way we help them understand it's not going to get any better with
Right.
non-use.
Right.
It actually gets
Yeah.
worse,
It does. And
right?
that's what I like to tell, especially my guys, but women too. That is one part of the body. If you don't use it, you lose it. The atrophy is incredible. And for men, you can lose girth and length if you're not actively using your penis.
100%. a
Hmm.
100%. And I think they get freaky a little bit after prostate surgery, right? Because,
Yeah.
they hear the statistics. Oh, I'm going to lose this, I'm going to lose that. And
Yep.
I'm like, well, only if you're not doing what we say. So,
Right.
Stephanie, with our men that we are lucky enough to get right?
Yeah.
We literally teach them elongation techniques.
Okay.
Do you know what I mean?
Yep.
Holding at the base of the shaft of the penis, going to the tip to
Hmm.
elongate, like, to teach them. And if you think of it, the shaft and the texture, like, moving it every direction it should move
Hmm.
in. So, like, every tissue should move up and down, side to side,
Yep.
rotation. And we teach them, hey, all this tissue has to move.
Yeah.
Like, we make sure surgically they're past their
Right.
time frames. You know what I mean?
Yeah.
But we're delicately trying to help them understand, like, yeah, if you don't touch it, it's not going to
Hmm.
work again. Do you know what I mean?
Yep.
If you're not actually you're not going to do that to any other muscle in your body.
Right.
You're not going to just leave your quads alone and now you can't get out of your chair
Right.
or your glutes. And this is
Yeah.
no different than that. And so I think they just don't know if they haven't had someone sort of help direct
Right.
them. Do you know what I mean? In
Yeah.
it. So I think, what you're talking about is so great. I love it that you have posters in your office.
I do.
I need to get some posters in mine, bro.
Yes.
But I mean, it's just, I think if you don't explain it that way, that it's
Yeah.
just a bunch of muscles. And I think the other thing, especially with our men, and it happens with our women too, but like if you remember too, that after surgery, the autonomic nervous system, that fight or flight mechanism is kind of on high alert. And so then I try to tell them too, like, hey, letting go of that, being able to drop down in parasympathetic rest and digest. You and I are never going to have good sex, be able to digest good food. Do you know what I mean?
Yeah.
Have the fun we want to do.
Right.
If we're living up here like all the time, and don't get me wrong, we're all going to go up and down like that all day long because
Yes.
we all have some of these, right? But we also have to be able to learn how to do our deep breathing, learn how to bring that down. And that is a big thing I do with a ton of my men
Yeah.
because they come in and they're so upregulated that I have to teach them, and my women too. But I'm just saying,
Yeah.
if you never can drop down into rest and digest, it's a neural system activity that has to happen. And if no one ever teaches you how to do that, and maybe your parents were super high strung and super high functioning, hey, like, let us help you teach, learn how to do that so that you can actually enjoy sex, that you can actually get more blood flow so that you can enjoy it. Yeah.
Yeah. Absolutely, absolutely. And it's so important to, and for especially my couples that come in, the man is the one that's going through the cancer, but the wife is supporting him, and they all get a kick out of the guys who we take away their testosterone and they get their hot flashes. So the wives love that because they're going through menopause at the same time and they're having hot flashes. So they love that. But then you tell them that their husband's not going to get an erection for a while and they're like, excuse me? And so it's coaching the wives too, like, hey, if this is going to work, you guys got to work together and stuff.
100%.
The one thing that I think is so cool is the different wellness tools that are coming out to help with the vibration things, and the Tenuto 2 that has come out that really helps with all this. I think it's fantastic.
Absolutely. And in the neighborhood of my men in particular, just basic things, like even like I'll send them to Walmart, even, they have tiny little vibrators, they're not more than, I don't know, $20, right? And they've never used a vibrator for themselves. A lot of them, some of them have, but a lot of them not. But what are we doing is just maybe waking up tissue with vibration, right? Like teaching tissue new things because maybe tissue got kind of dulled out post-surgical, et cetera. And then, really utilizing the rear of the floor as well, like external anal sphincter to like actually give that lift and that support to the base of the neck of the bladder, just really teaching and training through all of that. But I love it. I happen to have one of the big chair stimulators, and a lot of people will say different things about it, but I mean, it's just an adjunct therapy, right? Like it's another component of a big picture. I'm not going to put anybody on there and never do anything else with them. It's more just some people, you're just trying to wake up the neurological system. And if it's been down regulated that long, like how do you do it? And sometimes, the electrical stim paddles, or even just some of the different stimulators. There's one that has an anal probe sometimes that we'll use to just, because a lot of times when the floor is like lost its power, the anal sphincter loses its power, right? Or lost its proprioceptive input. And that's again why we like to see them earlier. But I love all the stuff that's coming because it's going to help. And if you think about the spinal cord, we got vibration in a track, light touch, deep touch tracks, we've got hot, cold tracks. We're utilizing all these things to wake the brain back up. So
it's fascinating. And go ahead.
I was just going to say too, I want a lot of these men to know too, like if their back is stiff and their hips are stiff, how are you ever going to get the pumper action? So if the penile lift isn't happening as well as it did because the muscle sort of down regulated,
Mhm.
showing them where that muscle lies, right?
Mhm.
And then literally teaching them how to do the work, but then also loosening up their spine. So their lumbosacral
Yep.
spine, the thoracolumbar spine, and also their pelvis so that they can
Mhm.
do that pelvis rock to literally pump because a lot of my men have gotten super stiff after
Yeah.
surgery and their pelvic posterior rock pattern isn't even present. It's like all their pelvis just got stiff and then their
Mhm.
low back is stiff. So, we teach a lot of back extension work and a
Okay.
lot of pelvic tilting work posteriorly with the penile lift pump and
Okay.
standing, sitting, etc. Because
Mhm.
we're trying to teach people like, hey, if I don't have the nerves coming out of the spine well,
Mhm.
or maybe a nerve's elongation got disrupted,
Yep.
let's thread it by moving it, right?
Yep.
And then the system gets so much more efficient.
Yeah.
So our men we're having them practice in so many different positional patterns.
Mhm.
Like if they say, oh, well, I like to be on top or my wife wants to be on top, then we're practicing teaching them, okay, well, you're going to train in these positions because you
Beautiful.
can't get good at it by just laying on the bed and
Right.
training that way. Do you know what I
Right.
mean? Or
Yeah,
whatever. Like,
absolutely.
yeah.
Yeah.
So we're training them, whether it's sitting, whether it's standing, whatever it is, so that they realize, like, hey, you might have a position that you're better in,
Mhm.
that you actually can get a better erection in, like,
Yeah.
but you don't know unless you're practicing it. And then,
Right.
partners come into the picture with it. And I really want to encourage women or, whoever your partner is, like helping your partner move
Mhm.
through that too. Because
Yeah.
sometimes, like the sensory part, maybe with them touching, doesn't feel the same as their partner
Right.
touching. It does something different in the brain. And men
Mhm.
happen to be quite habitual
Yeah.
and the way they do things. I know that
Yeah.
sounds crazy to say, but they tend to have a habitual nature. Their wife
Yeah.
throws her leg over them in bed and they think, oh, she wants me.
There it
Like
is. Yep.
that's the way it always happens, right? Like
Right.
they're kind
Right.
of, there's something part of their brain. So, like, maybe figuring out, like,
Mhm.
oh, these things are triggers or signals that
Yeah.
actually signal a person's brain, whether it's a woman or a man, right? But
Right.
signals to them, and that their
Mhm.
brain then drops down in more
Yeah.
parasympathetic rest and digest, and then they can actually reach that point easier or
Sure.
differently maybe than they did before. But if you don't explore it, like, and don't
Mhm.
know, like, it's okay, it maybe doesn't work exactly the way it
Yeah.
did before, it's going to be okay, there's other
Yeah.
ways to do it.
Absolutely. And I think, especially during that time frame where maybe they're not getting quality erections, what a beautiful way to find other ways of intimacy. Work with your partner, find other ways to touch each other and things like that. And that way you still have that intimate connection, even though you're not having penetration or orgasms at that moment.
Absolutely. I think, Stephanie, too, like in a woman in particular, the
Hmm.
ischiocavernosis that comes up, it brings
Yeah.
all the blood supply to,
Hmm.
the clitoral bulb and all that region. So if my men come in with their women and they're working through things, I'll tell them, hey, all of this tissue,
Hmm.
you're working labia minora,
Yep.
labia majora. You're not just on clitoral bulb, you're working
Yep.
all this tissue. In the perineal body, we know there's erogenous
Hmm.
tissue, like up even on the pubic ridge, like right
Hmm.
below the ridge and like through the tissue in there, and like teaching them to understand it. So it's no different than if a man has a surgical
Right.
intervention, right? And they need that same sort of
Hmm.
touch pattern. We go back to be like, hey, here's the muscles that actually work at the base of the shaft of the front of the penis, to
Yeah.
do the penile lift. Here's the tissue that actually. So I want to encourage people, if you're out there listening, to know that when you're coming into pelvic PT, people are going to help you know where this is so that you're
Hmm.
not wandering around and just getting anxious with your partner and being
Yeah.
like, oh, well, you got a half erection and it was not even hard. I get some of that sometimes
Yeah.
in my office, and I'm like, okay, everybody, let's sit back down and
Yeah.
let's go back and let's talk through it, because these are just muscles and
Right.
they need to know what to do again. And they
Yeah.
kind of had a lot go on. And so let's help them.
Yeah. And, a lot of times in the absence of a surgical, when you're just starting to have ED and things like that, a lot of partners get disheartened because they think it's them.
Uh,
And that's one of the things that I love to break that barrier and say, it's not you.
Mhm.
They are still attracted to you. They still want to have sex with you. They want to blow your brains out. But they just need some help right now. So we need to focus on them. This is not a you issue. This is a them issue. But because so many, especially women, because we're so emotional in nature, we
I
take it
agree.
that we're not good enough. We're not doing the right things. He doesn't think I'm pretty anymore, whatever it is. And it's not the case.
Yeah, I 100%. That's wonderful that you said that, because I
Yeah.
think that's a statement that needs to be said, that
Mhm.
it's not about you as the other partner. They have
Yeah.
some stuff going on, and let's figure out and help
Mhm.
them with their
And support
stuff.
them. Yeah, exactly. Support
Yeah,
them.
and especially, so many, I think, men, it's part of their soul and who they
Mhm.
are as a man, and so it's very disheartening to them. They feel terrible that they're
Yeah.
not pleasuring their partner, or not able to deliver like they delivered before on the
Yeah.
goods. And so they're not sure how to handle it, and maybe they don't have the verbalization. So
Mhm.
women knowing, hey, you guys out there who are listening, like knowing, hey, you have to now take the focus off of you and
Yeah.
really move to them and say, hey, how can I help you move
Yeah.
toward this thing? And if they don't know, there's no shame or harm in getting a pelvic PT on board
Mhm.
who works in the sexual health world,
Yeah.
and literally can help explain, hey, these are all the things, these are things you work on, these are things you
Right.
practice, these are things you do, right,
Yep.
to help our partners kind of move in that direction.
Yeah.
Stephanie, so I want to ask you, do you send people, like if you have a prostate cancer
Mhm.
patient, do they go to pre PT at all?
Yeah, so in my office, I do prostate cancer. I
Okay.
don't have a robotic surgeon in my office, so I send them to a couple different ones within our practice at different
Okay.
offices. So
I see.
they have their own protocol, but I believe that they usually start at least 2 visits prior to
Okay.
surgery, and then
Okay.
afterwards. Whereas I'm dealing with more of the guys who are on the hormone therapy and the radiation,
Gotcha.
and they don't tend to buy into pelvic floor physical therapy as easily as the surgical guys because they know they're getting cut and they can need therapy.
Yeah.
And so that's one
Yeah.
barrier that I try and work through with them. But yes, I do. We send people a lot.
Yeah. I was just curious if it was before. I know in the
Hmm.
oncological world I work in, I always am trying to get my surgeons to like send
Yeah.
early, even if it's just for a visit or two for baseline,
Yep.
because then we know at baseline, where they're at,
Hmm.
because maybe they weren't having great erections before, even
Right.
so. But then now they're like, oh, but you don't know because you didn't see them. So we ask
Exactly.
a lot of questions and a lot of things pre-operatively, just
Yeah.
so, or before even radiation starts, so that we at least have an idea. And then we talk through, like, hey, what's what do you want to do, like how
Hmm.
much do you want to work on this, how much do you want to
Yeah.
kind of. And I think that's important too, to realize that if these are endurance muscles. There was a study years ago, it came out, I think it was in an oncology journal, but it was about, you lose endurance muscles during radiation
Hmm.
because you don't have all the energy level, so that you're maybe not doing what you would normally be
Sure.
doing, right? So they
Yeah.
lose a lot of endurance. So aging,
Hmm.
any oncological work, any surgical stuff loses endurance. So think of the
Okay.
floor, 70% muscles that
Yeah.
are endurance muscles. So if you think about that, and I know a lot of people think, oh, it's just quick muscles. Well, I'm not saying you don't lose quick muscles too, but
Yeah.
they really saw the drop off quickly within the
Hmm.
first 2 or 3 months
Yeah.
of so any endurance muscle that you
That's
and I
really
have,
interesting.
right? And
Yeah.
so I think that helps people realize too, like, hey, I don't want to lose any of these muscles. So like,
Right.
if I don't start for 3 months later, do you know what I mean? That's not going to
Yeah.
help me. So I really try to get people like going faster, because we know that, the moment then that they have endurance
Hmm.
issues, I mean, that's going to affect the floor in so many ways. Do you know what I
Yeah.
mean?
Yeah.
And so I think that's why, if we can capture them quicker, sort of help them know, like, hey, this will prevent some of this, because those endurance muscles are dropping off, because radiation is hard on the system,
Yeah.
chemo is hard on the system. So even if they didn't have a surgical intervention, those things, and we see that in our women as well, just so you know, like
Okay.
it's a thing.
Yeah.
And so we like really encourage people. So like, maybe you're not bad here. Okay, we baselined you out. We know what your
Hmm.
muscle test is, but but let's keep tracking you, even if I saw them every week or every other week or whatever,
Yeah.
to make sure as they enter into that period. I think it's just a preventative thing, because
Yeah.
for whatever reason, and you know it, you probably see it so much, is that, it's a cumulative effect
Yeah.
many times of radiation that, I may have somebody who did great their first whatever
Mm-hmm.
months, and all of a sudden, boom,
Yep.
like they're like 10 times worse. And I'm like, oh
Yeah.
my gosh. And I think that's where knowing that the musculoskeletal system is such a powerful component of the floor,
Yeah.
and if we can kind of get in there quicker, you know what I mean, and
Mm-hmm.
not let the atrophy happen, we'll be way ahead
Yeah.
of the game. So
No,
yeah.
that's fantastic. So does pelvic floor physical therapy, this is coming to me as we're talking,
Yeah.
help with my guys who have the radiation and they get the burning, the urgency, the frequency? And like you said, it's not the first week or two, it's later on.
Mhm.
Should I be sending them to physical therapy as well?
Yes, because part of what you're trying to work through, like with them, and I'm pretty global when I'm thinking, but like,
Yeah.
think of it, that radiated tissue shortens, it gets tighter, right?
Yeah.
And neurological tissue wants to slide and glide.
Yep.
Everywhere there's a nerve, I got artery, vein, and lymphatic system. So I might have a lymph system that's not as efficient, right? So I
Mm-hmm.
might have a little more edema in an area, a
Sure.
little bit more swelling. Then I'm not getting as clean a blood flow in and out of the neighborhood.
Yeah.
So I like, I don't know how to say it, but like I beg my people, oh, like give them to us early, because we just see. I'll just tell you, one of the guys, I'm just going to brag about him. His brother had prostate cancer and told him, when he got diagnosed, his
Mm-hmm.
brother said to him, you have to go to pelvic PT. He goes, it's the only thing that saved me. So here comes
Very
this
cool.
guy. I mean, I ended up he's such a nice guy. He drags in, he said, my brother said, I have to see you before surgery, and I don't want to do it. It was this
Yeah.
whole thing,
Yep.
right? And I'm like, okay, that's great. So he came in, I think it was only 2 or 3 visits. And I'll never forget the urologist afterwards. I think he was in for his 6-week checkup. She goes, oh my God, you are doing so good. How could you be doing so good?
That's
And he goes,
awesome.
well, I went back to therapy at 3 weeks just so that we could figure out, like,
Yeah.
hey, where are you at? What's working? What isn't? Like, how do we advance you?
Mm-hmm.
Gentle stuff. We weren't being aggressive, but just the fact of ranging things,
Yeah.
even if it was them just passively doing it, it made
Mm-hmm.
all the difference in the world for this guy. And his biggest goal, he wanted to get back on his bike and be able to bike. And you can
Yeah.
imagine his floor did not feel good in the
Yeah.
beginning. And he was like, he would come in and be like, can I ride yet? And I'm like, well, I don't think you have the tonal pattern to bike, because,
Yeah.
your sitter bones are here and you're going to be pulling apart at that base of the floor where the perineal body is. And you're just not strong enough. You don't have enough endurance.
Yeah.
Work. And, he comes in now my office sometimes just say hi, and he's like,
Yeah.
I just want you to know I'm biking 60 miles, I'm doing,
That's
like
awesome.
he's, yeah. And
Yeah.
I only say it because I think it's, if we talk about it like you're just
Yep.
saying, and we get the word out, like, hey, we're not going to tell you never can do this again. We're going to say,
Yeah.
let us help you figure out how to get back to whatever it is that you want to do. But if you don't see us, we can't train the muscle if we don't see
Yeah.
you,
Yep.
and that's the hard part. Because there's just probably not enough of us to do it
Yeah.
all. But we're
Yes.
working hard to make that better. But I just want you to know, like, Stephanie, like
Yeah.
that thought that you had is so important, because yes, I mean, we want that mobility, because mobility
Yeah.
creates like motion for the nerves, motion for the blood flow in and out of a region, and it
Yeah.
helps to pump the lymphatic system out. So even if
Okay.
they're just doing little things to pump the
Yeah.
lymph system out, with motions that maybe in the beginning are just easy and gentle and they're passive. And if you looked at them, you thought, oh, that's not much, but it's enough to create motion in the
Mm-hmm.
pelvis, motion in the floor. And then people just feel better because
Yeah.
they feel like, oh, I'm in control of it. Otherwise, you know what happens? They get staticky and they
Mm.
close up,
Yeah.
and their whole system closes down.
Yeah.
And man, by the time those people come in, think of it, if I've closed down like that,
Yep.
now, I get this, so much of the nerves, come out of our spine that
Yes.
feed the floor, feed
Yeah.
our legs, whatever. But I always look at it like any anterior pain. I'm
Mm-hmm.
always looking at thoracolumbar junction. Hey, our nerves moving. who feed the front of the body. And then down at the lumbosacral area, hey, if things aren't moving down there, they filled all the posterior part of everything. So it's a general way to be like, hey, if I'm all closed up, there's no way that spine is even getting the neurological pull pattern. So I got to get them up. I got to get them moving. I got to get them doing things quickly. So a lot of my men, we have them walking very early, like, like up and moving, gentle, because we need them to actually move, because otherwise all that stuff's just going to get tighter, with radiated tissue. So.
Oh, that makes so much sense. I love that. This has been such an amazing episode. Like I've learned so much from you. This is fantastic. And I know my listeners have too. Before we wrap up, tell me about your podcast so that people can listen to you as well.
Thank you. You're sweet. So I have a podcast called Femtech Health. It literally, even though it says it's femtech, it really is getting the word out literally about maybe new innovations that are coming, new ideas that people are sparked through, new thought processes that people have about like new research data. And we're just trying to get so much communication going, and everybody's podcast reaches different audiences and different people, right? But we're trying to do it so that people actually have a vision that they're not alone, right, in it, and that somebody's out there actually thinking about whatever their problem is. And so I think that's the beauty of it. Like, I think we lose hope. Like, I mean, just in the pelvic organ prolapse world, it can happen sometimes with my women and my men in the prostate cancer world, especially. Like, we lose hope if we think, oh, well, no one even cares that I don't feel good and I have burning and I'm like have pain every day. And you're like, no, actually, there's a zillion of us out here with our little brains going around. Like, I can see that you are already. That, it might spark the light, the podcast for someone else who's been thinking about something, right? That says, oh, maybe I could do that. Maybe I could do something that would actually make a difference for this particular population, for this particular way. And it's so beautiful. I think, like, you're a clinician, and you're talking about things from this clinician standpoint. And then, you start talking to people who are business people, and you start to talk to government, or you talk to different. But why? Because when we start interacting like that, guess what happens? Like getting all collaborative, and we come up with 10 times more solutions. And we don't want to just stay in our own box. You're brilliant, and you're looking at things and you're trying to say, how do I solve these problems for the people that I see every day? Okay, let's get that out there in the world, because there might be some engineer out there who says, well, I got an idea. You know what I mean? Like, I'm like, good, because those are the only ways, right, that we make the difference and the change, I think, in healthcare long term. And I think that's just what I'm about. Like, I don't want to keep talking about the problem. I want to come up with solutions that we figure out how we're going to actually change this so it's not a problem anymore for anybody, right? So I think that's the reason for the podcast. It kind of came out of my own heart of like, oh man, like I want to know who's out doing what for what, like,
Absolutely.
and then get people together to talk about it and come up with things. So, and I think that's sort of the way, like, just with pelvic health check, it's kind of my radar thing right now. Just like we have breast cancer checks, I want to really get this to take off, where there's pelvic floor checks, so that it becomes just normalized. Just like you and I go in to have our teeth checked and cleaned and that we don't tell a woman, oh, well, you're not having babies anymore and you don't have your period anymore, so we're not going to look at your pelvic floor. And the same thing for men. Like, okay, they'll tell me sometimes, I'm like, well, who's looked at? Well, I had my prostate checked, but that was it. I'm like, okay, well, how long have you been irritated down here? How long has that tissue not felt very good? Between your perineal body as you were biking 70 miles. You know what I mean? Like,
absolutely.
We want people living like that.
That's amazing. I love it. That's such a great podcast. So Femtech is the podcast.
Femtech Health.
Femtech Health. I love that. So we'll in the show notes, there will be links for you. We'll put the podcast information in there as well, so people can find you. And Sheree, I just so appreciate you being here today. You've been just a wealth of knowledge and energy, and I just love it.
Oh, thanks for having me, Stephanie. I've been following you for a while, and I I just love to see people. I have tons of nurse practitioner friends in there. I vibe with them really well because they are all about trying to make a difference, and I love it.
Yes.
So thank you for all you're doing. I really appreciate it. And thanks for
Oh,
having
you're
me.
welcome. Yes, thank you so much. And everybody, we'll catch you next time on Between the Sheets. Have a great day. Thank you for listening and spending time with me today. You can catch new episodes of Between the Sheets every Wednesday, because what better way to add some spice to your life than to have a new podcast on Hump Day? We will continue to explore common, uncommon, and taboo topics related to sexual health and wellness. Please send any comments, questions, or stories to podcastbetweenthesheets@gmail.com. That's all one word, podcastbetweenthesheets@gmail.com. Have a great day. And remember how important it is to discuss these topics with your friends, your family, and of course your partners. In fact, you can like, follow, and share this podcast so they can see it too. See you next time for more sexual health topics Between the Sheets.